Good morning and welcome to today's webinar, Strengthening Care for Kids, an overview of the Children and Family Specialty Plan. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's topic is the Children and Family Specialty Plan. A panel discussion and Q&A session will follow the presentation. At this time, I'd like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you very much, Dina. Hello, everyone. Thank you for joining us today. My name is Kelly Crosby, and as Dina said, I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I'm also a licensed clinical social worker and a person with lived experience. My first professional, paid job as a master's level clinical social worker was actually supporting children in therapeutic foster care. So these were children in foster care homes who were receiving therapy. So it was my job to provide therapy for the children, education, support, and training for the foster homes. And so this group of kids means a great deal to me, and I know many of you today. That's why you're here, and also our panelists. So today, we're not going to do a bunch of announcements. We're going to get right into the topic of our discussion because it's really important. Very soon, the Child and Family Specialty Plan will launch. And we want to make sure that, to the best of our ability, we are supporting people to understand what that means, what the plan actually is, how a child might go into the plan, what that means for their services. And to do that today, we have pulled in a panel of experts. So I'm really excited to introduce our experts right now. So as each slide comes up, I will introduce them by name. You'll get to meet them as I ask them questions, but I'll actually introduce them so we can get into the heart of the session. So if we can do the next slide, our first guest is one of our DHB, one of our Medicaid colleagues, Shamika Jackson. She is the Associate Director of the Child and Family Specialty Plan at North Carolina Medicaid. Next slide. I think you all know Dr. Keith McCoy. He's the Chief Medical Officer here at our division. He also has a dual role. He's the Associate Medical Director for Behavioral Health at North Carolina Medicaid. Next, we have Dr. Jaylon Close. She is an Associate Medical Director here at our division, DMH DDSUS. She also has a dual role. She's an Assistant Medical Director for Child Behavioral Health at North Carolina Medicaid. Next guest, we have Sandy Danner. Welcome, Sandy. She's the Associate Director of Member Operations at North Carolina Medicaid. We have Mr. John Thacker. He's the Provider Network Director of the Children and Families Specialty Plan. So this is very exciting. We actually have members from the Healthy Blue Care Together. That's the name of the North Carolina plan, the Child and Family Specialty Plan. So we're super excited to have Mr. Thacker here with us today. And then, oh, I thought we had one more. We don't have one more, y'all? My bad. I thought we also had one more guest. All right. But first, I'm going to turn things over to our expert, Shamika Jackson, and she's going to do, before we get into the panel and ask questions, she's going to do an all-over overview of the Child and Family Specialty Plan. Over to you, Shamika.
Thank you, Kelly. I want to really take this opportunity to do an overview of the Children and Family Specialty Plan. It is our newest Medicaid managed care health plan in North Carolina. It is a pioneering plan. There is no other plan like this in the United States, as it is one of those, a single statewide health plan that is going to be serving children in foster care, those receiving adoption assistance, as well as those enrolled in the former foster care eligibility group. This plan was going to be managed by Blue Cross and Blue Shield of North Carolina under the name Healthy Blue Care Together. It will be statewide, and we are set to launch on December 1st as an integrated Medicaid managed care health plan that's going to cover that full range of physical health, behavioral health, pharmacy, non-emergency medical transportation, enhanced care management, long-term services and supports, as well as some services for IDD and unmet health-related resource needs. Next slide. The unique components of this plan, it's a single statewide contract, and so there's only one children and family specialty plan, and as I stated earlier, that will be managed by Blue Cross and Blue Shield under the name Healthy Blue Care Together. This contract was awarded this way because we wanted to lessen disruptions in the continuity of care and be able to maintain treatment plans whenever these children, youth, and young adults switch geographic locations. There's a significant amount of coordination that happens at the state and local level between Medicaid, the Department of Social Services, as well as the Eastern Band of Cherokee Indians Family Safety Program for those individuals who would like to opt into the program. This is a family-focused approach to care delivery to strengthen and preserve families, prevent entry into re-entry into foster care, as well as support reunification or any other permanency plan options. While we understand there is also that person-centered approach, this plan also focuses on family as well. The benefits included are all of our Medicaid state plan benefits covered by our standard plans, as well as most of the tailored plan benefits, including 1915 I services. And lastly, the care management model really connects the plan with our local DSS offices in a very intimate way, so much so that there will be a lot of co-location between Healthy Blue Care Together and the local DSS offices. From an eligibility standpoint, the CFSP is set to serve those children and youth who are currently in foster care, those that are currently receiving adoption assistance, and young adults under the age of 26 formerly in foster care at age 18. And this is important, like we have young adults who have aged out at age 18 in North Carolina, but this plan also serves those young adults who aged out of any state in the country at the age of 18, as long as they aged out on or after January 1st of 2023. We also are going to serve the minor children of those individuals that I just named, right? And so their children will be auto-enrolled into this plan. And of course, the Eastern Band of Cherokee Indian Family Safety Program and those that are currently informally served are eligible to enroll in the CFSP, but they will not be auto-enrolled, but they will have that option. And so in our unique components of the program, we did talk about some of the ways that we are addressing the current challenges. But I just want to call out, we've designed this plan specifically for the child welfare population to mitigate the challenges that we've had over the years with our bifurcated system, right? And so we've been serving this population through regional LME MCOs and Medicaid Direct. So that's CCNC and our regional LME MCOs. And so you have guardians and individuals who are having to work across systems. And so we've designed an integrated health plan that will be able to mitigate some of the challenges that come with a bifurcated system, such as disruptions in continuity of care, a lack of sufficient care coordination, and then just challenges with meeting the needs of the population without having a specific lens of focus on the population that's being served. And of course, that includes like the limited service array specific to the needs of the child welfare population. Next slide. Some of our program objectives are to improve near and long-term physical and behavioral health outcomes, right? At Medicaid, we want to do that with all of our programs. We also want to increase access to care. We want to ensure that there's timely access to care, strengthen and preserve families. And so as I stated earlier, we really want to assist with preventing entry into foster care and really support reunification or any other permanency plan options that are available to these children and families. We want to coordinate care and facilitate seamless transitions for those members who may be experiencing changes in placement, transitioning in and out of foster care, or just into adulthood. We want to improve coordination and collaboration between local DSS, the Eastern Band of Cherokee Indian Family Safety Program, and more broadly with our community collaboratives. And also, we want to prevent children from boarding in local DSS offices, as well as our emergency departments. We want to ensure that we are preventing that. And lastly, we want to advance health equity for this population. And so a lot of individuals are asking, well, what will happen until CFSP launch? And so until CFSP launch, from an enrollment perspective, a Medicaid enrollment perspective, most of these individuals are continuing to be enrolled in NC Medicaid Direct until December 1st of this year. And so with that, there are some individuals that are already enrolled in a tailored plan, right? And so if you're on an innovations waiver or a TBI waiver, you would not be in Medicaid Direct today. You would already be on a tailored plan since you would not be transitioning to this program. Next slide. From a care management perspective, today, for those children, youth, and young adults who are not tailored care management eligible, they are receiving their care management services through CCNC or CMARC. And CMARC is for those young children with complex healthcare needs. And so that's for those individuals that are not tailored care management eligible. For those that are tailored care management eligible, those children are receiving the tailored care management through their LME MCOs or through a tailored care management provider. And they will continue to do so until December 1st of this year. Next slide. From a timeline perspective, we're getting really close to December 1st. 33 days, I believe. Yes, I've been counting it down. And so there have been a lot of activities that have happened. Notably, like on October 5th, we did auto enrollment. So in the Medicaid systems, it's showing that these children, youth, and families, these children, youth, and young adults are enrolled into the CFSP with an effective date of December 1st of this year. With that, our enrollment broker did send out those notices on the 9th, 8th, and 9th to ensure that these members receive notice that they would be enrolled into the Children and Family Specialty Plan. And that went to adult members, it went to guardians, including those DSS guardians as well. There's also the primary care provider and care management auto assignments that started happening on October 17th. The NEMT service line went live on October 17th as well. And so members who need to go ahead and schedule their NEMT rides for December 1st and beyond, they can go ahead and do so. Our nurse and behavioral health line will go live on November 1st. We will be mailing those member ID and welcome packets starting November 3rd. And so the members will have more in-depth information outside of the enrollment broker notice on what CFSP is. They will get their ID card. It will show who their primary care provider is and all of those things. And then all of this is preparing us for that 12/1/25 CFSP launch. So as you can see, there's a lot that has happened, but there are still a few things to come to ensure a successful launch of the program. Next slide. As it pertains to transition of care, we really want to ensure that we're able to maintain continuity of care for these beneficiaries. We also want to minimize the burden on providers as we are transitioning these members into managed care. As with previous launches, that comes with flexibilities. And so as you'll see here on the screen, we are relaxing those medical and pharmacy PA requirements. And so those PAs will be relaxed through June 30th of 2026. For those non-PAR or out-of-network providers, they're going to be paid at in-network provider rates through June 30th of 2026. They're also going to be able to follow those in-network PA rules through October 31st of 2026. And for primary care providers, our members are going to be able to switch their primary care providers as many times as they need to up until June 30th of 2026. And then there's the continuity of care for ongoing course of treatment. And so any treatment that a member is getting today, that shall continue through June 30th of 2026 without disruption. And so these are things that we've put in place because we really want to ensure that these members do not have disruptions in care, but also that our providers have reduced burden and are still able to care for these members as we transition to this plan. And I'll close out just with letting you know, like those last two slides kind of got us to this point, right? Our day one priorities, everything we're doing to ensure that these children, youth, and young adults are getting the care that they need on day one, that our providers can submit claims for payment to the plan on day one, that these members can access the necessary medications, that they do have their ID card in hand, they have that prior to launch so that they understand who they're going to be cared for from a primary care provider in advance. We want to make sure that everything is set up so that they have the right information at the right time from this program, that the provider networks are adequate, and that members do know who to go to with any questions around the provider network. And then lastly, we are going to make sure that we have people ready to answer the phone at those call centers for any questions that may come up from members and providers. And at this time, I'll pass it back over to Kelly Crosby. Thank you, everyone.
Thank you so much, Shamika. So really appreciate that overview. And now I'm going to ask the panel members to turn their cameras on and join me on camera, please. So here's how we're going to manage the panel. Obviously, we have questions ahead of time prepared for our panel members. And a lot of these questions are questions that have occurred in listening sessions or other webinars across the state, or even just questions we get when we're out and about talking to members of the community, engaging with our CFAC. So that's where the questions are largely generated from. There will be time at the end. You're all submitting questions in the Q&A. We're tracking those, and we'll do to the best of our ability. We'll cover those if we don't get to those in our prepared panel sessions, okay? So everyone's got their camera on. We also have, just so you know, it's not just the panel members. We have additional folks waiting in the wing if we need to phone a friend from Medicaid, from Healthy Blue, from DMHG DSUS. So lots of people are here because we really want to help share as much information as possible and answer questions. So I'm going to ask anyone from the group to jump in, but I do want to ask Keith this question first. So Dr. McCoy first. Like you're a clinician, you're a physician, you're a policy guy. I know I've worked with you forever. So why are we launching the CFSP? Why do we need it?
Sure. I think that our current managed care system is divided based on clinical need. But Medicaid deals with a host of things that aren't necessarily fundamentally diagnosis-based, for example. So our tailored plans have, serious mental illness, severe substance use disorder, intellectual and developmental disabilities for a subset of people. Our children and youth and their families that are involved in the foster care system aren't easily identified just based on diagnosis. They're going to have a whole range of medical and medical-related support needs and non-medical needs. And we have a pretty complex system of social services in North Carolina, and that it's county-based. And so from a Medicaid perspective, one thing that's really important is that we have a plan that has a single locus of accountability for us related to children, youth that are in foster care and their families, that we have as comprehensive as possible of a service array that's integrated so that we can have that same whole person approach, and that we can have really targeted and incentivized integration at the DSS level. And so those are some of the important pieces from my standpoint that are vital here. And then also a really robust care management program. We have a lot of care management programs in North Carolina, but one that's particularly focused on foster care seems important to us. But I'm guessing probably some others have some additional commentary to add here.
Anyone else? Hop on in.
I can jump in to say that the kids who are in foster care often have unique mental health and health challenges. And I think as Dr. McCoy touched on, this plan will be focused on that population and be able to very specially address their needs in a holistic way. And so I think that having a very specialty plan and associated care management staff will be beneficial for this population.
All right, thank you both very, very much. And I think Shamika covered some of that as well in her introduction, like a lot of the considerations that went into this. But the bottom line is really, we are looking to create the best system of care for kids who are in the foster system who are aged out. And there's a lot to navigate across both the medical system, the mental health system, the IDD system, the DSS system. There's just a lot to navigate. So we want to make sure that all of their comprehensive whole person needs are met within one plan. So Shamika or Sandy or both of you, can you remind folks again who is actually eligible for the plan?
Yeah, I can restate that for you. So it will be the children and youth that are currently in foster care today, those that are currently receiving that adoption assistance, the former foster youth who aged out at the age of 18. That's for those that aged out in North Carolina and outside of North Carolina. And that will be up to age 26, as well as the minor children of all of those individuals that I just named. They will all be eligible for auto enrollment into the CFSP program for December 1st. And our tribal population is eligible to opt in.
And all this information too, it's on the slides and we'll share the slides as we always do, but Medicaid has also shared and posted additional helpful information explaining some of that, right, Shamika?
That's right, Kelly.
Okay. And our team, if we can, make sure that we can link to those sites as you always do wonderfully in the chat so folks can see those. So when will a beneficiary or their guardian or their provider know that they are now enrolled in this child and family specialty plan? Sandy or Shamika, you want to take that one?
Andy, you want me to take it? No, I can take it. Okay. You can go ahead, Sandy.
Okay. So enrollment packets have already been mailed by our local enrollment broker. Our enrollment broker is our third-party entity that provides counseling for health plans, but they have already mailed enrollment packets. So individuals, their authorized reps, will have received these packets saying that they will be moving to CFSP effective December the 1st. And it also provides them with their options, the other health plans that they may be eligible to receive.
Kelly, you're on mute.
Thank you. And I got an automatic prompt too. So thank you for that. So just to reflect back, Sandy, everyone is auto-enrolled. That's come up a lot in the questions, actually. So I'm just reemphasizing that. Kids are auto-enrolled. Those enrollment packets that explain their enrollment have already gone out, but also information if they or their guardian wants to choose a different plan. So there's information on that if they want to choose a different plan. So I'm just keeping on this. Do they have to do anything to enroll?
They do not have to do anything to enroll. They are auto-enrolled only if they want to change their health plan.
Okay.
And that packet provides information on the plans, the different options the individuals are eligible to receive. So it would only be if they want to change their plan, would they need to reach out to the enrollment broker.
What if you think you should have gotten a packet and you didn't, or you'd like to enroll in the CFSP? How could you do that?
So that's a good question. You can reach out to the enrollment broker, and the enrollment broker website is North Carolina, Shamika, I think is North Carolina Health Plans.gov. But you can go on their website, you can chat with them, you can also reach out to them, call them. They, like I say, they are our third-party vendor that provides choice counseling to all individuals. You know, you can also reach out to your DSS, your local DSS, and say,
Okay.
hey, am I going to be enrolled in this program? Now, the DSS will not be able to provide choice counseling or change a health plan for the individual. They will have to reach out to the enrollment broker for that. But for some basic information, they can also contact their local DSS.
Okay. So that's very helpful. Can any Medicaid beneficiary sign up for the CFSP?
No. I'm sorry. Shamika, can you take this?
No. So you must be in one of those categories in
Gotcha.
foster care, receiving adoption assistance, former foster youth, or one of their children.
Shamika,
Thank-
I know we're saving the questions till the end, but one came in that's very related here, and I think it's kind of important because this situation happens a bit, right? So what about children that are in DSS custody? They were in foster care, but now they are living with a relative. DSS still has custody. Is this child going to be in the CFSP?
That is a great question. Thank you for asking that. For as long as that child is in the legal custody of the local DSS, that child will be auto-enrolled into the program.
Okay,
Thank you for
that's
that
really
question.
helpful.
Yeah.
Thank you. Okay. All right. I think Sandy covered that. So let me dig in a little bit more, Sandy. You said that folks are getting their enrollment packets. They can call the enrollment broker if they're interested in a different plan. So who gets to make a decision? Like, who gets to determine, I'm saying I want this minor to go into tailored plan. I like the services there better. I don't want to be in CFSP. Like, who can make that decision and how does it happen?
So what happens, especially for our foster care population, once a child comes into DSS custody, the director or the director's designee, well, actually the director has guardianship over that child.
Okay.
So therefore, the director and the director's team determines who is going to have that authority to make those decisions. So that may be the director, it may be a joint partnership between the director and maybe the child welfare social worker, the permanency planning worker that is overseeing that child. It does have to be a legal authority for a child under the age of 18. So if you have a guardian, if you have a power of attorney, something like that, those are going to be the individuals that can make those decisions for those foster children. Now, if you are 18 or over, let's talk about our former foster care population. For those individuals, they are their own representative, and they can actually contact the enrollment broker and discuss their healthcare options and make those decisions. But for those authorized representatives, like I mentioned, it's going to be the director or the director's designee. That information will be provided to the Medicaid team. And that Medicaid team will enter that information into the North Carolina Medicaid system. So the enrollment broker will have that information, and also so CFSP will have that information. So they will know who is authorized, who they are authorized to talk to regarding that child.
Okay. Wow, that was very thorough and very helpful, Sandy. Thank you so much. You've got quite amazing expertise in that space. Okay. So and this is very weedy, right? But it's come in as a question, can that guardian determine that they want the child to stay in Medicaid Direct? So the basic Medicaid package, not tailored plan, not standard plan, but just good old Medicaid fee for service.
So North Carolina is moving towards managed care, and we are so excited about moving towards managed care.
Yeah.
So North Carolina Medicaid Direct is no longer going to be an option for this population. These children will have multiple options of other health plans, either standard plans, tailored plans, or CFSP, which will be their auto enrollment. But North Carolina Medicaid Direct will no longer be an option.
Okay, that's really helpful. So we talked a lot about how you're auto-enrolled, who has the authority to ask to change, how that might work, where you could change. But let's talk about the benefits then, okay, right? Because Many times changing might just be about a benefit concern you might have. So let's talk a little bit about the benefits. So will a child and family specialty plan's doctors, therapists, it's a member, I'm talking about the member. When they go into the CFSP, is their doctor, the clinicians they see, their medication, is their access to those people they're already in a relationship with going to change? Who wants to take that? Keith, you want to start?
Sure. So we have network adequacy standards that drive all of our managed care plans as to how many of each type of provider must be available in order to meet those standards. We also have layered on a lot of monitoring because there's going to be significant transition, right? These are kids and other folks that are already in services. They're already engaged in the Medicaid system. And so we want to go above and beyond what our network adequacy standards are. So we've been monitoring for disruption in behavioral health providers, disruption in primary care, disruption within hospital systems and specialists. Those are pieces that we've been monitoring really carefully. So the hope, there certainly will be, because of the way that managed care works, not every provider is going to elect to be in every plan. There's ongoing contracting, which I'm sure John can speak to, efforts in order to make the provider network as robust as possible. But we feel, based on our monitoring, that we're in line for a good effort to try to minimize disruption at launch related to that. Plus, we have the flexibilities around being able to pay out-of-network providers who may not have contracted yet, not having to do new prior authorizations, those sorts of things. The pharmacy list is the same for all of our managed care plans. We have the same preferred drug list. We have the same requirements for coverage in PA. So there should not be any disruption there. I don't know if others want to weigh in on anything that I may have missed here.
Oh, that was a thorough answer. I would add where continuity can remain, we certainly want that. So in reference to our providers, so long as they're contracted with Healthy Blue Care Together, and they would like to access that particular provider, we desire to have that provider in network with us. So to the audience, if you are currently not contracted with Healthy Blue Care Together and you're interested in contracting with Healthy Blue Care Together, we have information that we would like to share with you. You can reach us at nc_provider@healthybluenc.com. And for contracting questions, you can reach us at nc_contracting@healthybluenc.com.
Thank you so much, John. And we've got that now in the chat for folks to see. But what I hear is a theme, and I'm going to break this down a little bit more. I'm going to break it down into mental health and substance use services and services for people with intellectual and developmental disabilities. So hold that thought. But what I'm hearing overarchingly, right? Medications, the same medications are available across all Medicaid plans, period. And what I'm hearing very loud and clear from both John, who's representing Healthy Blue Together, but also the state team who's been working on this, that a value and a priority is we want people to be able to maintain their same primary care doctors, their same specialists. That is a goal. And John has given an invitation for those providers who are not enrolled. There's a way to connect. So he wants to connect with you. There are some differences. Shamika said this, okay, but I think it's important for us, given our typical audience, to talk about differences a bit. I want to talk about in the CFSP what mental health services there are or aren't, what's different, and then IDD. But let's talk about mental health and substance use. So is the whole array of mental health and substance use services that beneficiaries may know, are they all available in the Child and Family Specialty Plan?
Yes. So we've got the full array of our substance use services. So everything from basic outpatient to our intensive outpatient, comprehensive, residential, all the way to inpatient. We have those are going to be in this plan. We have our full array of mental health services, again, going from outpatient to some of our community-based enhanced services like intensive in-home, day treatment, multi-systemic therapy. We've got some of our facility-based services, including our child residential array, in addition to our crisis services that may be facility-based, partial hospitalization, inpatient, our state facilities, PRTFs, those are all going to be there. What's not in there in CFSP, there are some folks who may need state-funded services. These are services through the Division of Mental Health, Developmental Disabilities, and Substance Use Services, contracted through the LME MCOs in their role as tailored plans. If someone needs state-funded services, they'll need to be in the tailored plan system in order to access those after 12/1. Those will continue to be available through the LME MCOs only. So there are some like group homes for adults, those types of things on the mental health substance use side are there, and we can talk about IDD separately.
Thank you so much for that, Dr. McCoy. And I will add that, of course, as Keith has already spoken of the transition, so there's a lot of work going into identifying the services and supports people currently have to try to maintain continuity of care. So we have identified folks, and it's a very small number of people who will be transitioning into the CFSP that have state-funded benefits. As you know, most kids and young adults have Medicaid, so they will be able to maintain their Medicaid services and benefits. Very few have state benefits, and so we are working with the LME MCOs to transition those folks to other services. So that's on the state-funded side only. I'm only speaking on state-funded. I'm not speaking to Medicaid, and it's a very, very small number of kids. Most of you probably don't even know what the state benefits are, just to be clear, right? Because they're very rare and unique. All right, but let's talk about intellectual and developmental disabilities for a moment. This is the most important question. Please hear this today. Hear this. If someone is on the CFSP in that plan and they get on the innovations wait list, do they leave the CFSP?
No, if you're on the innovations wait list, you can remain in the CFSP. There are some services, which we'll talk about here shortly, that are IDD specific, as well as TBI, that are in the CFSP. But if you're on the wait list, you don't have to be in the tailored plan. You can be, you can make the choice, but remain in the CFSP. And one, I saw it pop up in the questions, one additional set of services that may be unique to each health plan, and some of those may be mental health or substance use, are in lieu of services. These are services that are in lieu of a state plan service. So it's an alternative setting, it's an alternative set of interventions. It's got to be clinically, medically appropriate. So it needs to be based on some model that's got good evidence, and it needs to be cost effective. So no more expensive than the state plan service. Each plan has their own unique set of those. CFSP has a lot that overlap with what the tailored plans have, but there may be some unique ones that are only available through the tailored plans.
Okay. Thank you for that, Dr. McCoy. So if you're on the CFSP and you're on the innovations waitlist, great, no issues. If you're on CFSP and you're just hearing about the innovations waitlist and you want to get on it, please get on it. It will do nothing with your CFSP enrollment, okay? So how about the innovations waiver itself? Can you be on the CFSP and get an innovations waiver slot?
So you can get assigned an innovations waiver slot. So while you're in CFSP, you might get assigned one. You might need to apply for an emergency slot. That can be done from the CFSP. But once you have that slot, you need to move into the tailored plan. So those who are in foster care who already have an innovations waiver slot, or they're part of the CFSP population and they may have a TBI waiver slot, they're already in tailored plan and they will not be moved out of the tailored plan. Those innovations and TBI waivers are specific to the tailored plans.
Okay. And does anyone have to do anything to, because you said, Keith, if you get a slot, right, an emergency slot, or your number comes up and you get your innovation slot, do you have to do anything to move to the tailored plan, or is that something that kind of happens automatically at the state level?
Our system will move you once you
Okay.
have that. So you wouldn't need to do anything extra
Great.
There's a lot of process that goes into getting that slot
Getting
up
your
and
slot,
going.
yep.
That's very active, but you won't have to do anything to change your plan. That's something that the state will do.
That's right. Okay.
Can I add one thing?
Please, Sandy. Yeah.
You would need to reach out to your Medicaid worker to make sure that is in the North Carolina Medicaid system. So you would make sure, you would definitely need to touch base with the Medicaid worker for that foster child, just to make sure they have the correct paperwork.
Very helpful, Sandy. Thank you for that. All right. Let's talk about some other benefits. Are CAP-C and CAP-DA services in the CFSP? Anyone?
They are not. They will remain in the NC Medicaid Direct system.
Okay. How about the 1915 I-Option services, things like community living supports, respite, those really important services? Are they in CFSP?
They are. So the only two places those will be is Tailored Plan and CFSP. And then we also have them in Medicaid Direct for those who remain there.
Okay. How about ICF or in lieu of ICF services, intermediate care facilities for people with intellectual and developmental disabilities, or as Keith mentioned, we have some in lieu of services for people. Are they in the CFSP, Keith?
They are not. So ICF is a TP only service. It is also in NC Medicaid Direct. And then each of the tailored plans have in lieu of services as more community-based alternatives for folks who might need an ICF slot. So these are going to be in-home services, support services. They may be residential services. These are typically for individuals that are 16 and older, but that subset of services are only available in the tailored plans because only the tailored plans have ICF to do a service in lieu of. We have a similar service that's called a B3 service that's in NC Medicaid Direct. That's available for that population. And those are functionally the same, but because of the different authorities of the different types of plans, one is called in lieu of and the other is called a B3.
Okay, thank you for that, Dr. McCoy. So I have one more question. Is RBBHT, or what a lot of folks like to call it ABA therapy, is that available in the CFSP?
Yes, our services for children and youth with autism, which is what's covered under RBBHT. These are treatment intervention services different than our home and community supports type services. So active treatment interventions to try to reduce disability. Those are in all of our plans, actually. So that's in standard plan, that's in tailored plan, that will be in CFSP. It is also in Medicaid Direct.
Great. Okay, excellent. We're going to talk about care management in a minute. I'm going to ask John a question first before we talk about tailored care management, because got a lot of questions about tailored care management, right? Want to get to those. But I have an ask of our, maybe not our panel, but other folks waiting in the wings. We have 50 questions already. So if any of our colleagues that are waiting in the wings to answer questions, if you could, if you know the answer, type in the answer to some of those questions so we could get that out to the audience, that would be really helpful. Okay, so I invite folks to start to answer some of our 50 questions if you can. All right, John, over to you now. We talked a lot about the differences in services because that's really important, right? Continuity of care, meds should be the same, trying to get all medical specialists in primary care network. The mental health services are largely the same unless you get a state-funded service. There are some differences in IDD in terms of the innovations waiver itself, not the waiting list, and ICF services. Keith has already mentioned that tailored plans, because they're a health plan, as well as standard plans, can offer in lieu of benefits, so special benefits that are just part of their plan. So John, that's what I wanted to ask you. Do you have any of those special in lieu of service benefits in the Child and Family Specialty Plan that you want to share with folks here?
We do. Thank you for that question. We have quite a few in lieu of service definitions that we have submitted, approximately 18 in total. We are working our way through the approval process for many of those in lieu of service definitions. We're excited to bring these to bear because they will be accessible statewide. And so many of those services that perhaps were once regionally based will now be accessible across the state. So we're really excited about that and excited about offering those in lieu of services to members who perhaps have not had access to them before.
That's a lot. Wow, that's a lot. So I think folks are going to be really excited to hear more about those, John. So thank you. All right, let's talk about care management, y'all. Okay. Many of the panelists today have talked today about, and we've talked broadly for a long time about the vital importance of care management and how this is a very particular care management model in the CFSP. It will be closely aligned with DSS because they've got a lot of requirements too to support kids, and those requirements have to work together and the team has to work together. So there's going to be a huge emphasis, or there is a huge emphasis on the importance of care management in the plan. So how do members of the CFSP get a care manager? How does that even happen?
Yeah, Kelly. So we have a robust care management model. First and foremost, every child in the Children and Family Specialty Plan will be assigned a care manager. So every child, no matter their age, no matter when they come in, that assignment will take place within 24 hours of every child coming into custody. In many instances where the counties have discretion or allow or have space, we'll have many co-located care managers in many of our DSS partners' offices. And really, it's what you spoke about. It's really to have that close shoulder-to-shoulder relationship with our DSS partners. And so they will be easily contacted. Our social workers or our partners will have contact lists. They'll be able to access their care managers by different modes, whether that be cell phone, direct outreach, co-location, email. We also have a platform called NC CarePoints Connect, where a lot of information will be housed. Social workers will have access to go to this platform and they can identify who their assigned care manager is, so that there's multiple ways and multiple avenues in which they can access that care manager. We desire to work in close partnership with DSS, and as such, we're trying to be as customer friendly as we can as it relates to those relationships and ease of those relationships.
Thanks, John. That's super helpful. So I hear that within 24 hours of a child coming into your plan, they'll get auto-assigned to a care manager. I'll talk about choice in a moment, but how about all the folks that just got auto-enrolled in CFSP? Did they also get a care manager, or do they have to choose one? Like, how does that work?
Yeah, so we're currently going through the transition process now. We're meeting with and have been meeting with our DSS partners. Every child, by way of that auto enrollment, will be assigned a care manager.
Okay.
And also, I want to clarify in terms of that assignment.
Yeah.
It's within 24 hours of notification from our
Gotcha.
DSS partners.
Gotcha.
And so once they make us aware of that, we'll have that assignment taking place. But rest assured, those children currently that will be crossing over into the CFSP, each of them will have a care manager assigned at Go Live.
So it's going to be assigned. So what happens if the guardian or the child would really like a different care manager? Is that a possibility that they can choose a different one?
Sure, they can make that request and we can certainly accommodate. Care managers are assigned based off of several factors.
Yeah.
Each of our care managers will live and reside in the communities that they serve.
Okay.
So they'll be local.
Yeah.
Two, we recognize that not every child has the same needs. And so therefore, our care managers may have some general specialties that might align them best with a child's needs or young adult's needs. So there are other factors that we take into consideration. But the short answer is, if there's a desire to have a change in care managers, that DSS can let the appropriate person know, and we can work to get that change done.
Okay, excellent. What if someone already has a tailored care manager? We've heard in the chat already folks who are concerned because they have a tailored care manager, they really like their tailored care manager. Can they keep their tailored care manager? How would that transition look or feel?
Yeah, so by way of the transition to CFSP on 12/1, they will be assigned an internal plan-based care manager through Healthy Blue Care Together. So that targeted care manager or that tailored care manager will remain with the tailored plans. Each child will be assigned their Healthy Blue Care Together care manager when they come to us.
Okay. So how is, and then John, Eugene, marvelous. It's awesome to hear from you. Anyone else can jump in as well on this next one, but maybe you just want to do it, John. But how is your care management different than tailored care management? That's why I invite others, because I expect John to be an expert in his care management, but maybe others are better expert in tailored care management.
Yes, sure. I'll kick that off.
Yeah.
Our care managers have a complement of specialties. And so what you might find through care management, say through tailored care management and even standard plan, consider that kind of the baseline for our care managers. Each of our care managers will have a whole health specialty. So we're addressing the whole health needs of each of our children. In addition to that, our care managers are supported by a team approach. They'll have access to care extenders who will be working, and these are individuals with lived experiences. And so they'll be there to support the child or young adult as they transition through services and their time while in the plan. In addition to that, there'll be a host of clinical care advisors and placement coordinators to help that care manager to help facilitate some specific needs of that child. So for example, each care manager is supported by a clinical care advisor specializing in things such as substance use, intellectual developmental disabilities, family preservation, transitions of care, etc. And so we like to think that the complement of services, in addition to the whole health approach, distinguishes our care management model from that of tailored care management and also standard plan.
Thanks, John. Anyone else want to add anything? I think that what I'm hearing is that there are some people on the call that really like their care manager and they think they're getting good services. So can we do anything to help? Because it sounds like they're going to transition. They may have tailored care management, but that's not a benefit in CFSP. Care management is, but it's a little different. So
that's
anything
correct.
You'd say to help folks who may be nervous about the transition?
Yeah, I think this call and understanding and asking questions, particularly when that change takes place, we desire for our care managers to be at the forefront of coordinating services, to be engaged with the different professionals on the treatment team, and to also, effectively run quarterback as it relates to those timely communications, those timely outreach, et cetera, working alongside our provider network. And so I would encourage folks that as we go live, those questions that you have, the relationship that you're looking to seek and form as it relates to that tailored care manager, please reach out to the assigned care manager so that they can become familiar with your services, your expertise, that we can begin forming those relationships as well.
I can also,
Thanks for that. Oh, Jalen, please.
yeah, I can also jump in to say that for anyone who's engaged with a care manager, especially tailored care management, there will be warm handoffs to the Healthy Blue Care Together CFSP care managers. And so it's not all on the member to update their new care manager, although I do encourage everyone to also talk with their new care manager about all of their health needs.
Thanks, Dr. Close. One final question in care management. Again, this is a question that's come in. Folks have heard that in the CFSP, so truth or myth, or can you explain this? Some people will have a plan-based care manager, but some might have care management through a community provider, which is how tailored care management happens. Sometimes the plan provides the care management or a provider does, but is it all plan-based, John, or do you do any contracts with another organization?
Yeah, thank you for that question, Kelly. So there is a segment or a subgrouping of our membership that will be delegated. CCNC will cover our adoption assistance population, while all other members, the eligibility that Shamika referenced earlier, those will remain with Healthy Blue Care Together through our care management model. So those are the only two care management entities for our entire population.
Okay, super helpful. And most folks know CCNC, and CCNC has been working with youth in the foster care system for many, many, many years. So it sounds like you're drawing on that expertise. A question that, before I move on to one of the toughest questions, we've gotten a couple of questions in the chat around primary care docs. We talked before about we're trying to keep continuity of care, get all folks in the network, but how are children in the plan being assigned to a primary care doc, and how are we picking those?
I'm not sure we have the right folks on. This may be a phone a
Oh,
friend
okay.
one for
Okay.
this specific group. Shamika or Sandy?
We are trying to keep those PCPs the same. So if an
Okay.
individual currently has a PCP, we are trying, Healthy Blue Care Together is trying to provide that child with the same PCP. If that enrollment is not the same, and I'll let John speak to this, it may be that they just have not contracted with that PCP yet. So hopefully they will be able to contract with that PCP, but we are trying to keep those the same for the children.
Okay. So we have, we're low on time. We have lots of questions. So I want to get a couple more questions in, but I want to say something to the audience, right? We're probably going to go about to 11:35. I don't want to keep our panel too long. They have other obligations, but I have a couple things I want to get in. So there's a lot of questions coming in. And so what I want to tell folks is, remember I said, the Medicaid team is here, Sandy, Dr. McCoy's in close, Shamika's here. They're here from Medicaid. We also have Medicaid folks in the wings. They're hearing all these questions. They're hearing the discussion. They're getting all the questions coming in. And so they are going to incorporate the questions you're asking into some frequently asked questions documents that they will be publishing. So know that your questions are incredibly helpful actually in helping them shape the right Q&A documents for the field. So great questions, keep them coming in. Sorry, we can't get to them all. We'd probably need a 3-hour webinar. So let's talk about authorizations for a second. Shamika covered this as well, but I think this is important, right? We talked about, is your provider in network? How do you get assigned to care management? What services are in the network? What if you already have services authorized? Do you have to get a new authorization when the plan starts? Is your authorization good as you go into the plan? How's that going to work?
I can start, and
Yeah.
John, you can come in if you'd like. So at transition, we call that the crossover period, and up until June 30th of 2026, those members that are coming in with those authorizations, they will continue those authorizations and can see those providers regardless if they're in network or out of network.
Oh, great. Okay.
Yeah.
How
And
long
there
does that
are
last,
relaxed-
Shamika?
You say what?
How long does that last? I'm sorry, I missed that
Up
part.
until June 30th of 2026. So
Okay.
that's a part of our flexibilities.
What if they're seeing a provider that's not yet in network? I think you just said that, Shamika, but
It's the same. They
Okay.
can continue to see that provider
okay.
up until June 30th, 2026 with the same relaxed PA,
Okay.
with those authorization repayment that still applies here.
Okay.
And Kelly,
All right.
during that time period, kind of my
Mhm.
plug earlier on is that if they're not contracted,
Mhm.
as Shamika said, we will honor those services. Our desire is to bring them under contract in network with us, and so we will be identifying those providers to bring them into network.
Okay. So I know Shamika has a hard stop, so thank you, Shamika, for joining us. Just 2 more questions, I promise. So we've got a lot of questions actually about health plan accountability, which makes sense, right? We want to make sure that the health plan's doing a good job. I won't get into those. I think they're very important questions, but people also want to know what went into the decision to decide that Healthy Blue was ready to launch on 12/1. I do think it's important to talk a little bit. There's a lot, I just know, right? I was at Medicaid forever. A lot of rigor goes into making these decisions about go live. And there's a lot of rigor around launch and making sure it goes well and everything else. But like, how did Medicaid decide you all were ready to go, or CFSP was ready to go?
I can get us started. So this is not our first launch. We've done this numerous times. We continue to, we hope, get better at it. And there are thousands of data points and demonstrated capacity that get evaluated, measured, reported on, assessed, that gives us confidence in an overall, go, no go decision. And so based on the many years of experience we have with this now and the demonstrated capacities by Healthy Blue Care Together, Medicaid, all the way up to the secretary of HHS, made the decision that we had what we needed to be able to move forward. There will always be issues. And we have the other thing that we assess is what is our ability to mitigate risk created by places that aren't quite perfect, where we don't, we're not getting 100s on everything, that all the sample claims go through perfectly or whatever it is. And so we have mitigation strategies that we also have in place for Go Live. We have a command center. We have the ability to handle things in real time when there are issues at Go Live. So we have a relatively sophisticated system when it comes to our ability to assess for readiness and then to actually launch and mitigate the risks associated with a new launch.
I think you were on mute, Kelly, for that question.
Thank you, and sorry. I think I never did this before. I just said thank you for that. Anyone else want to add anything else? Anything? Okay. All right. So last question. What will, we heard a lot about this phrase, transition of care. What will transition of care look like? So I'm talking about people that are currently receiving services, have authorization, maybe have a care manager, maybe have very complex needs, are worried about falling through the cracks. Is there anything special that Medicaid is doing with all the current plans that those kids are enrolled in as they switch over to the CFSP?
I can also start us off there. I think one thing that has been talked about is that there's a lot of flexibilities to continue with current providers and receiving current services through June 30th, 2026. The department and Healthy Blue Care Together have also come up with ways of identifying people who have high needs, both from a mental health and physical health standpoint, and are paying special attention to make sure that warm handoffs happen as soon as possible, and that Healthy Blue Care Together is aware and paying special attention to people who might have higher needs. And so there's a lot of thought going into making sure that people don't follow through the cracks.
Thanks a lot, Dr. Close. Anyone else want to add anything? All right. We have about 30 seconds left, and there's a lot of topics still to cover. People have a lot of questions, so I'm really glad we had a lot of people join today, send us a lot of questions, because that helps us get better at explanatory documents, additional presentations we might do. So we're very appreciative that folks came today. Any closing remarks from anyone? Before I hand things over to Dina?
Just appreciate the participation. This is a plan that was built with enormous stakeholder input. And we still have things that we're working for in this plan that will get implemented over the next several years. So it won't be in its final version. But the stakeholder engagement around this has been extraordinary and couldn't be done without the participation of stakeholders like those that we have on this call today. We appreciate your process of holding us accountable to making sure that this is a successful launch.
Thanks so much, Dr. McCoy. With that, I'm going to turn us over to Dina to end the webinar.
Thank you, Kelly. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. Also, questions entered in the Q&A pane will be included in a frequently asked questions document that Medicaid will post. The recording and presentation slides for today's event will be posted on our Community Engagement and Training webpage. For more information and resources, stay connected with DMH DDS-US by attending our monthly side-by-side webinars and joining our mailing list. The links are included in the chat. There will be a brief survey following today's webinar, and we would appreciate your time completing it. This concludes our event for today. Thank you for attending.